Great. Hi, everyone, and good afternoon. Thank you for joining us today. So my name is Chelsea Pelche. I'm an associate professor in the School of Health Sciences, and I'm one of the members of the committee who organizes this seminar series. Just want to acknowledge that today I'm in Prince George, which is the traditional territory of the Lheidli T'enneh, and some of you may be in different areas right now. So before we get started, we want to acknowledge our contributors and sponsors to this seminar series. So the School of Health Sciences, School of Nursing, and School of Social Work at UNBC, as well as the Northern Medical Program and the Psychology Program. We also receive some financial support from Sun Life Financial. So if you have any questions about the seminar series, or if you have any suggestions for speakers, please reach out to Bree at the HRI. We also visit our website where you can find a schedule of upcoming speakers as well as the recordings from prior presentations. So as a reminder of our upcoming schedule, on March 18th, Margot Greenwood will be presenting. And then our last presentation day in April will be a showcase of our undergraduate honors students. So today, I'm pleased to introduce two speakers, Dawn Hemingway and Leila Zimmer. Dawn Hemingway is an associate professor in the School of Social Work and has an adjunct appointment in gender studies and health sciences. Her teaching and research interests include aging, caregiving, community-based research and policy development, and northern rural health issues, with a particular interest in women's health. Dawn is also a member of numerous advisory and advocacy groups in the province, which were just too numerous for me to name today. I'm also pleased to introduce Leila Zimmer, who is currently an adjunct professor in the School of Nursing. Both of these presenters today are members of the Leadership Council of Northern FIRE, which is the Feminist Institute for Research and Evaluation. And I will let them, or I think Leila, share her slides and begin your talk.
Perfect.
Okay, I don't know, am I on mute?
Well, you're not on mute. And
okay.
the slides are so thanks very much for the introduction, Chelsea, and for the opportunity for us to speak about this research today. I'm Dawn Hemingway, and I'm going to just begin our presentation. Leila will take over at a certain point. I'll come back. It's a little less smooth, but we may try and jump in on each other if there's additional comments we want to make as we go. And then we look forward to any questions or discussion at the end of the presentation. So to start, which you can all see, we're looking at an examination of the health needs of older women who are experiencing precarious or no employment in Northern British Columbia. This is a project that was undertaken through Northern FIRE and also with funding from the SHRC and some through UNBC as well. The other thing I guess I'd like to say before I begin, just to provide a little bit more context, is that in addition to Northern FIRE as a research center here at UNBC, also the Northern FIRE has what we call the Women North Network. And that is an electronic network, perhaps a little old school. It is an email listserv of several hundred women serving organizations and others interested in this work across Northern British Columbia. So just to give you a sense of the totality of the work that we do, we're very community-based. So I'd like to just provide now the introductory note that is the next slide. And this is very important to us as an institute that is very much engaged with community and community actions and activities and initiatives. So the partial data that's provided in our presentation today, it really aims to initiate discussion by giving voice to the women who shared their knowledge and experiences with us. And we really value their words. It's quite a privilege to have been able to speak with them. We seek and pledge to work toward social change that gives rise to a good quality of life for those involved in this research and for everyone, such that each person can contribute to society in whatever ways they are able. And that introductory note reflects the positioning of Northern Fire and of the Women North Network in all of the work that we do. So in terms of what we're going to talk about today, the study itself is a mixed method study, and we sought to explore the experiences and opinions of precariously employed or unemployed women who were 45 years of age or older, living in Northern BC, and looking at what did they think was the meaning of health, what were the social determinants in their perspective, access to services that impact their health. Did they have them? Didn't they have them? So just broadly getting their input about how they viewed health and the kinds of supports and health services that they might or might not have. And I guess an important piece for people to be aware of is that this study really came out of an earlier study, which was done around the health of Northern women 45 years of age and older. It was a study that had a large survey that was circulated electronically across Northern British Columbia with 155 electronic responses and paper copies using the contacts and organizations and community groups that we were connected with and that they then were connected with to kind of fan out some hard copies for people to be able to complete who were not interested in doing it online or didn't have the possibility of doing it online. And through that work, we received over 250 responses. And then we did 9 focus groups, which on average had about 10 people. In total, there were 90 people that participated in the focus groups. So you might think, well, that's, it's a fairly substantial sample, and why would we need to do this again? The next slide begins to speak to that. We did have really excellent response to the first study, but after we started to look at the demographics collectively, we realized that we really had not reached some of the people in the population, some of the women that we really wanted to, especially women who were facing some really significant challenges with respect to job security and employment, and just some of the things that may well affect their experience of being in and considering what it's like to be in Northern BC in terms of health. So in particular, we looked at the criteria around education, income, and some others, and really found that we were missing a lot of women who were living on really precarious kinds of income situations, either not working, low wages, just basically those who we just didn't seem to capture through the first study. So we therefore decided that it was really important to do a follow-up where we explicitly sought to have women who were 45 and older, who self-identified. So these were women who themselves identified as being precariously employed and who wanted to have their voices heard around the question of their health. So moving to the next slide, we decided at this point that we would, I think we're going back one slide, that we would look at doing surveys, interviews, and focus groups with women who self-identified with that criteria. And for this study, we also decided to include some focus groups with frontline service providers. And what we're doing today in terms of providing you with some sense of the study is giving you a preliminary analysis of data from 12 individual interviews with women and one of the service provider focus groups. I should say that the way we, of course, you might wonder, how did we find these women if they didn't come forward the first time? We used very much our contacts, at least as the starting point. Many of the women and organizations that had connected with Northern Fire and with Women North Network over its first years of development, when we did a whole series of pieces of work that had us traveling out to other smaller communities outside Prince George. So we used those contacts, people that we knew who were providing services. We did things like try and get our posters into drugstores and grocery stores, whatever we could think of where we thought that we would be able to reach women. And having fairly good community connections, we were able to do this work, I think, successfully. So in terms of the questions that we asked in this process of the actual interviews and the focus groups, the thrust of those questions for both the one-on-one and the focus groups were as follows. So really just talking to people about, how do you perceive the meaning of health and being healthy? What does it mean to you in your situation? Most important personal health needs and factors that you thought influence those needs. So really with just telling people to just say what comes into your mind, the first thing that comes into your mind, and then you can develop on it further. Don't think too hard about it. Just what are the most important personal health needs? What things influence those needs? And one of the other questions that, of course, was important to this particular study was to talk about and hear from these women what any unique needs they felt that women who were 45 and older might have as compared to a younger cohort of women living in Northern British Columbia. Other questions that we talked about with them were just in terms of addressing those needs, the things that they've identified, what was actually working for them and what wasn't working for them. And in that discussion, it started sometimes with very specific responses, sometimes with very broad strokes. But either way, we found that the women were very interested in providing that information in terms of what was working and what wasn't. And not, you might think that mostly it would be what's not working, but there was also some discussion about what's working as well. Then we looked at asking them what barriers did they see to having their needs met. So were there any specific barriers? So we know what's working, we know what's not working. What is stopping you from being able to have those needs met? And then wanted to talk about with them those who were working in precarious situations. What was the impact of their employment situation on their health? Did it impact them at work, outside of work, in life in general? So what was that impact? And then finally, looking at other kinds of barriers. So what else that you may not have been able to describe yet because it didn't fit one of our questions, what else do you think is impacting your health and your wellness? So those were that sort of sets up the study. And I'm going to turn it over to Leela to talk a bit about what the voices of the women themselves told us. And then I'll come back and talk about some of the things that we learned from the focus group with those service providers that we also wanted to hear from in this study. Service providers who were providing supports to precisely these women who were living with precarious employment or no employment.
Okay, before I go into the actual words from the women, I'd like to tell you a little bit about the women that we interviewed. I would say, certainly my impression is that these women are largely invisible. They aren't people that are noticed or particularly taken into account. In terms of their health, aside from the problems of aging, which many of us start to experience after 45, a number of them had chronic conditions, such as arthritis, epilepsy, and diabetes. A number also talked about mental health challenges. Some were formally diagnosed psychiatric disorders. And other than that, it would just be depression, loss of hope, that kind of thing, just struggling. A number also had experienced sexual violence and trauma in their lives, and that had a huge impact on their health ongoing. There were some who'd had past problematic substance abuse or substance use. And then a number just spoke about isolation and loneliness. Not really feeling they had the support that they needed. In terms of accessing health services, this was generally discussed with a fair bit of ambivalence and an indication of distrust. And many of these women were not receiving the health care that they needed, partly because of that distrust or other barriers that they experienced. In terms of living situations, some of our participants actually lived in women's shelters. Others, of course, lived in their own very modest accommodation, and in some cases had sole custodial care for grandchildren or were the primary caregivers for other family members. Dawn has spoken about work and the fact that they are precariously or unemployed. Though many didn't give us specifics about their work situation, it was evident that some worked seasonally in camps and things like that. Others had jobs, for example, janitorial, cleaning jobs. But essentially this was work that might be considered by some as menial labor, certainly not well paid. And some of those who were unemployed due to disability. So when we asked them about what they understand or what the meaning of health is for them, it was there was pretty much consensus that it's definitely more than physical. It includes mental, spiritual, and emotional. For example, as represented by the medicine wheel. This was raised. So one participant said it's the whole picture and environment that people are living and that they are satisfied with their life, having a reason to get up in the morning. And your self-esteem falls into having that purpose. So clearly, purpose, employment, connections with others are key to their health. Another woman said, being healthy to me looks like having enough rest, having enough exercise, having enough healthy and nutritious food, having a good environment in which I live and work, having a good support within my family and my circle of friends, my coworkers. And it would be having a healthy support of women in my life of all different ages. It would look like having the ability to maintain my life in the quality that I choose to live. So you can see the sort of holistic sense of health to these women. Safety was very important, and this came up in different ways. It was safety in terms of housing and work, but it also had to do with adequate transportation and just the activities of daily living. They all wanted in one way or another to be independent, to be able to support themselves and to access what they needed. Family was very important. They wanted support from family and friends and to be with family as much as possible. And access to healthcare, access to all the things that they need. And sometimes this was adequate nutrition. Sometimes it was having their healthcare needs met by the services in the community. All sorts of things like that.
Sheila,
Okay.
could I just add about the family, if I'm,
Yeah.
I'm remembering one of the women, and just the fact that being able to support their own family and be with family was quite complex sometimes, because it wasn't just their situation, but also the situation of their family members who may not be in the immediate household, but overall were also struggling. So it reflected a desire to actually begin to be able to deal with the things that were challenging, not only maybe for themselves or even in their immediate household, but looking beyond that to their family in the broader sense.
Right. Thanks, Dawn. So when they discussed what the most important health needs and the factors that influence those needs were, income security was pretty much number one in terms of needs, but also food. There was, some of them experienced real food insecurity, particularly if they were diabetic or you know, had a problem that related to what they were able to, their elementary needs, let's put it that way. Housing, certainly, and a healthy environment socially and physically. And as you will see from some of the subsequent quotes we're going to give you here, that wasn't always what they had. Good healthcare services, education, and counseling. So as I said, a number of them had mental health challenges, so the counseling is an important piece. Factors that influence these needs are poverty, disability, mental health, and social and physical isolation, lack of access to services or cuts to services that they had previously accessed. Often prevention and screening was not available, or if it was available, there were barriers to them accessing it. And barriers that prevented them from leading what they considered a healthy life. So in order to maintain good health for these women, it's a constant struggle. And not only that, they feel that problems which really lie systemically kind of get blamed on them, blaming the victim. And this was sometimes evident in social and cultural issues that they raised.
Maybe I'll just add around the question of the blame for being blamed for systemic problems. Like, it was really a challenge for many of these women to be able to, you know, they had the sort of fight in a certain sense that they wanted to deal with these systemic issues, but they were trying to live, you know, just live their life. And being able to deal with those was really, really difficult. They recognized them, which to us, I think, you know, they really felt them. But then, and even in some cases, we're trying to get engaged to do something. but just trying to eke out, you know, a life made it very, very difficult for them to be able to fully engage in the way they might have in other circumstances to address some of those systemic issues.
So here are some other quotes that demonstrate the issues and the factors that they're confronting. The factor is poverty. You can do all the prevention you want, but people still can't afford their salmon. And I mean, in our society, it's your income that really determines how you live. Also, there have been so many cuts to basic services that teeth are considered a luxury. So dental care just didn't exist for these women. Lack of hope really affects your health. And you can see, I mean, from what Dawn just said, if day-to-day life is simply trying to get the bare minimum of the basics that you need, it's hard to maintain hope. And you know, these situations affect not only people from Canada, but also immigrants. People coming from their own countries cannot get their professional status recognized. Very stressful, can lead to lots of health issues.
I think that's something that for us at the university is something to really think about, because even in terms of our professional programs and the requirements that our various boards have for people coming to this country who have had the training and practice in other locales, it really caused me to have a very strong look at what is the College of Social Workers requiring, for example. And is it, you know, is it just, you know, like of course we want to make sure that people have the qualifications and can be held to account to, you know, if they're working with people in situations as in social work we might be, or in nursing or other areas. But it does give pause for thought about what criteria we have and how we value or don't value other systems of teaching and other, you know, other countries' programs. So it anyway certainly made me think about that in a different way,
Mm-hmm. As I mentioned, many have chronic conditions that they're living with. This participant said, within the physical manner, I do have arthritis fairly pronounced. It is considered a disability, so I need a lot of support with that, because there are certain things that physically I cannot do. If I don't have help with those things, I can't accomplish them. Then of course that plays on the mental health. So even for this particular participant, just getting up and down stairs to her apartment was a huge struggle. Not to mention getting groceries, getting the drugs that she needed from the pharmacy, all that kind of thing. Another participant said, and this speaks to what I described as a history of sexual violence and trauma that many of these women have come out of. I never knew until I was 36 years old that I'm not supposed to just use my body to throw at men or women who wanted to abuse it. I just assumed that it's okay to go out there and get money for it. So we know that poverty drives many women to work on the street, and that is fraught with all kinds of vulnerabilities and health challenges, health risks. Here again, speaking to past history of substance misuse. I became an alcoholic and a drug addict. I've been in jail so many times for smashing things. People I never knew why until I sobered up. I got counseling for my childhood sexual abuse. So once again, the importance of having those support services, counseling that's available to them. And this mother said, I taught my little son, I think he's healthy today. that as parts of the most beautiful thing, and they're not to be used for anything rather than to love, honor, and respect. So, as Dawn was saying, family members were hugely important to these women. And many of them spoke of their children and grandchildren, as well as spouses or spouses who were deceased. And the little that they had, they were concerned to expend it in terms of energy and resources to make life for their families as good as possible. So this is a bit of a summary. So some of these unique needs then were a difficulty to find suitable work. So work that pays only poverty wages, and ageism. If you're 45 or older, it's hard to find a job. Increased caregiving responsibilities for grandchildren, spouses, parents, and others. And then health issues that were either not recognized by care providers or not addressed, either due to the women's ambivalence of seeking care or just disregard on the part of care providers. So one woman said, freedom 55, you can do all this wonderful volunteering. In reality, the responsibility for women often increases taking care of partners. And another said, look how much money is paid to men's erections and how much research is done for that. But nobody wants to talk about the fact that I pee my pants when I sneeze after so many kids. So as women age, they have particular physical problems. Just to summarize a little bit here, some of the sort of barriers they face in terms of employment were ageism, racism, sexism, and just really inhumane working conditions, bullying and harassment. So in terms of ageism, I know there's a lot of discrimination in employment, a lot of ageism, even though there shouldn't be. Even people who are very qualified will have a very hard time finding work. And then speaking to those who kind of create the barriers, usually they're in some sort of government or management, making more money, making rules, making policy, doing research. So a little bit of a dig at those who are not precariously employed and who don't think carefully enough about those who are. In terms of bullying and harassment, this was one example we were given. There were others. On the res, they forced everybody to go out to work. And I was already on disability because of herniated discs and fragmented discs in my back. They just drove us like slaves. There were no breaks. The days start for everybody at 5. There was a community constant noise. We got about 4 hours sleep at night. We worked sometimes 14 hours a day because if our work was not good enough, we had to go back. Every day they tell us, someone's going to be fired today. It could be you. And then in terms of sexism, this woman said, that's why I left some camps. I just wouldn't put up with the stuff. It's all men, right? And I grew up with all men, all brothers. I never think of it, but I realize they have their own different sexual or whatever. But I didn't, but I realized I leave a lot of camps. That's why I'm so picky on camps, I guess. But nowadays, it's very different. Experience as a woman at home is the same as in camp. So for some, sexism wasn't just an issue in their employment situation. It's something they were living with constantly.
I wonder if I could just, Lila, just make a comment back on the ageism slide. Just, you don't have to go back to it necessarily, but I, it's one of the things that I heard for sure, and just in other roles in my life, this really had a profound impact on me. Well, I'm of the age too. So, you know, well over plus 45. But just listening to, you know, just how these women felt about the way they were treated, even if, you know, those who they describe as, you know, government or management or making more money, even if those who are creating the rules and regs and having the discussions with these women feel that they're being, you know, quite appropriate. It was a really profound thing to hear them talk about the fact that that is not how they're receiving this information. They are feeling that ageism. And it doesn't matter if we can say, oh, well, you know, you can get, you know, you can get your pension, or you can get your guaranteed income supplement if you're not making that much on your regular pension. But really to feel that profound just sense of not being valued that those women were feeling. Anyway, just another one of those things that really had an impact on me in just hearing how they were feeling about their situation and how they were viewing those who were making policies. So I just wanted to add that.
No, thank you. Yes, absolutely. And I mean, when that one woman at the beginning, when we were looking at their understanding of health, said something to get up for in the morning. I mean, that's part of it. These women still have a lot to contribute. And they're just being ignored, basically disregarded. In terms of racism, we have a couple of comments here. There were lots. And I have to say that the data from these women was really rich. And I mean, these quotes we're providing are only some. There were many, many gems and many really shocking stories that we heard. But this woman said, I did a lot of traveling to research sexual abuse. I always find that people don't look at Aboriginal women as anything other than sexual objects. We grow up thinking that is just what we're meant to be. And I mean, we all know the Highway of Tears and all of the terrible sexual violence that's gone on in our region. Much of it has been racially based. Another woman said the health authority has posters of Aboriginal women with HIV is not a bad thing. How about a poster with an Aboriginal woman and a healthy baby on it? So just these sort of subtexts of racism throughout their experience.
And really another example of, you know, what people may feel, you know, we're doing something that's positive, for example, by having a poster that says HIV is not a bad thing, you know, so you view that as you know, not trying to discriminate, to you know, etc. But at the same time, you know, how people are perceiving that, and, you know, like in terms of their own lives, and what about, you know, our lives and the positive things that happen in our lives. So anyway, just another one of those things that really hits close to home, I think.
Exactly. So I will let you take over from here, Dawn.
Oh, okay, sure. So I'm going to talk a little bit about one of the service provider focus groups. And I should start off by saying that these service providers were primarily community-based service providers of various kinds, so providing health and social services within the community. And they were, anyway, I would say they were genuinely concerned about the extent to which they were able or not able to provide the kinds of supports to these women that they felt they should be able to provide. And you'll get a sense of that from just seeing some of their comments. So the first thing they talked about in terms of addressing health needs and our question about what's working and what's not working. And so one of the women said, this is in terms of what is working. Being such a small community, we really network well, and the referral process is a little bit easier. We do activities together, find out about each other's mandate, networking. So we really reach out to women that are isolated. And then again, I think our community spirit, pioneer spirit of helping. So we take it on. And I think we all have seen that in our own work and lives, how, you know, in many cases, we don't have the resources that we necessarily think we should have in the northern part of the province, but somehow we get creative and we try and figure out how to make it happen. So you innovate to figure out how to do it even with fewer resources, with less access. And so there is that sense, you know, that we know one or two things about how to solve some problems. And I know sometimes when we are given the southern part of the province as an example of how things are really being done well, we can think of a few examples where we figured out some things ourselves. And I think that sentiment, it definitely came through from these women in this particular focus group. And they were proud of that, you know, that we can sort out some of these things and we do our darndest to be able to do it. At the same time, you'll see in terms of addressing what's not working, they certainly saw what was not working. Lots and lots of concern about access to resources and services. So lack of access to basic services, to transportation. And one of the quotes here, a real lack of resources in the north, increased needs, increased health risks, yet we get less of the resources. I remember one of the discussions was also, which has changed somewhat in the last few years, but I think is still an issue. And that was the question of having funds allocated on a per capita basis. So not taking into account the different geography, the distances, the different things that people are facing in a northern community. So that whole question of yes, you can do per capita funding, but are you looking at the environment and the things, the natural and the social environment that people are dealing with? Then another quote, basic medical considered luxuries, or people you know who can get down to Vancouver on air ambulance, but you have to get yourself home. So looking at some of those, and of course, we do have some things that have moved forward over the years. We do have the bus, you know, we've got the bus that goes down, but there's so many parts of that that is just so different than if you're right there where there's health access to health services. I was talking with someone the other day who actually tried to sort of skirt the need to have someone with her to bring her back, because she didn't really have anyone to bring her back, and was trying to figure out how to get on that bus and not have anyone there to bring her back. So, you know, there is some improvements that have taken place, but there's still a lot of concern about being able to access the medical services that we need. And, you know, some people talked about not getting the medical services they need because it was just too complicated. They couldn't figure out stuff at home to be able to go and actually access some of the services that were available outside of Northern British Columbia. So these healthcare and community providers talked about some of those examples. And I think all of us have probably heard them in our lives and our work as well. So some very significant issues about what's not working in terms of basic services. Another question that they spoke about was barriers to having needs met, being one of the things, being attitude, how they impact service and access. And I think, I mean, Leela talked about this in terms of what some of the women said, but here's what some of the providers said. I have clients who don't want to go to the doctor because they feel judged. Social judging that people face makes them feel insecure and not willing to access health services, even if they're available. So even for those things that are available, people felt from the experience of these service providers that they just couldn't go. You know, they didn't have the right clothes. They maybe had to carry kids with them. They didn't have the appropriate food, the things that made them feel less than. And they just didn't want to have to deal with it. They didn't want to have to see people looking at them and feeling judged by anybody else, you know. And so it ties back, I think, to the question that the women talked about in terms of poverty, and all the things that go along with that, with mental health challenges, addiction issues, all the things that we've already heard from the women themselves. And really, these service providers, when they spoke about this, were profoundly impacted by this, that you could have people who actually would not go to get services because they're feeling like they're being judged. And one of the really big surprises for us, at least for me, I think it was a surprise for Leela too. And I should have said at the beginning, Indrani Margolin, also a social work professor, was part of this project with us. But one of the biggest surprises when we did this focus group with the service providers was them talking about themselves. And they, you know, they said, we are becoming our own clients. You know, like you can bring us here to talk about our experience of trying to help others and what we see, and we value that, we appreciate it. But, you know, they said, we want to talk a little bit about us at the end of this. And they did. And these are some of the quotes. You're thinking, holy, the health industry isn't there for me either. You have a job, but not able to afford basic needs. So if you think about many of these women in the focus group were working in community-based social and health services. And if we think about, you know, are there working and working conditions, wages, are they going to leave them in exactly the same situation as the women that we're just talking with, who were precariously employed, who were unemployed? And so this next quote really got to me. At the end of the day, by the time I'm done my job, done being a wife, done being a mom, done doing the volunteer stuff, because I believe you have a social responsibility to do something, you know what? I'm just too damn tired. And I get really frustrated and I start feeling a sense of hopelessness. And I just thought, wow, you know, isn't that the case? And then share this sentiment very much as well. Pay us what we're worth. Acknowledge the expertise of frontline workers, you know? So these women who are working on the front lines in downtown, whether it's in Prince George or Fort St. John or wherever it is, and giving their heart and soul to this. If you can hear that middle quote, you know, doing my volunteer stuff because I believe you have a social responsibility to do something. So they're doing their job, they're doing their volunteer work, they're doing everything else that is in their lives. And yet they're not, in terms of the sacrifices they make, they are not being compensated in the way that they ought to be. And thinking forward to the fact that they are going to have to live somehow when they're older. And are they going to be able to live on their pension? Are they going to be, or do they even have a pension? You know, I think hopefully most do now, but there were some that didn't. And so, you know, it was up to them to put money away, you know, to do an RSP or whatever, if you had any money to put away. So anyway, we were not expecting that. And when we heard from those women, we said that we're going to follow up on that. We're going to do another project that addresses those concerns that they have about, you know, what is happening with frontline staff who are giving their heart and soul to help people and working often overtime, with no compensation, just because they feel that they have to, they feel the social responsibility to do this. So anyway, the next slide talks just briefly about future research before we move on to see if there's any questions or comments. But one of the things that we're engaged with now is a large submission, a SSHRC grant called Understanding Precarity in British Columbia. This is a huge partnership. It's led by the Canadian Centre for Policy Alternatives in BC, as well as co-led by the Labour Studies Department at SFU. And here at UNBC, Northern Fire is involved, as well as some other faculty outside of Northern Fire, Jaleel Saifi and Fiona. Yeah, Fiona McPhail. And then those of us on the leadership team at Northern Fire, myself, Leela, Jacqueline Holler, and Indrani Margolin. But the thing I want to say about that study, first of all, is we are going to do, if this funding comes through, one piece we'll be looking precisely at what the experience is of these frontline service providers. But I wanted to say that it's a huge partnership. So there's academics, there's labor organizations, there's lots of community providers that are involved in this application. So many from this area. I don't know, I can't remember, Leela, if you were there, but when we had the big sort of get together to finalize this partnership submission, I think there were about 75 people on the Zoom meeting. So it's a very big team, and we'll know soon whether we're successful. But I have to say, we committed to those women, so at least I did. So even if we don't get the SSHRC grant, we're going to do that study to give voice to those frontline service providers. And I think we could maybe leave it there unless you have anything else that you'd like to add, Leela. Oh, maybe I'll say one thing. If people are interested in learning more about FIRE and Women North Network, we're going to be doing just an hour sort of intro to our work, summary of a lot of the projects, some of our new people who are newly engaged during Research Week. I think we're on the first day. I think it's March 1st. So that's another opportunity if you want to get more engaged. Or you can just email the Women North Network email. It's just wnn@unbc.ca if you'd like to even just get on the network and see the kinds of things that we're sharing with people across the North. So
I was just going to add that in terms of how service providers are underpaid, often community service providers in particular, as we all know, they live, those little agencies that are so important for providing services to women like the women we interviewed, survive from grant to grant. They are never sustainably funded. Yep. And with the funding that they do get, people who work for them are not paid adequately, as Dawn said. I just think that it's a huge systemic problem that our governments should be funding the services and the care for people who are precariously employed or unemployed, for those who live in poverty, and particularly women.
Absolutely. And the time that's spent applying for all these grants and not knowing whether you're going to be funded for them the next year, it just makes no sense practically even.
Right.
Yeah.
Yeah.
Okay. So
yeah, go ahead.
No, I was just going to say, are there any questions, comments?
So everyone on the call is unable to speak, like they're all muted. So if people have questions, please feel free to use the chat or the Q&A function, and I'm happy to read them out. Thank you so much for that talk and for sharing the stories of these women. Oh, here we go. We stop sharing. I have a quick question, I guess, related to COVID. I know you probably did this project a while ago, but do you have any reflections from the women you're still engaged with about how maybe it's changed during the pandemic?
Good question. Well, I can say one thing, that in terms of some of the work that I do that involves older women and men, but older folks in our community, one of the big challenges, and I guess it won't be a surprise, is just isolation. And although we've become much better at using Zoom, and so, for example, the Seniors Liaison Advisory Committee here in Prince George, we've been meeting by Zoom for however long since we couldn't meet in person. So we're getting better at that. But they talk about, because that's a representation of people from different senior centers and different agencies in the community. But they talk about the challenge, because even though we're able to have these meetings, the fact is that their own organizations can't do the things they normally do. So people can't come to, to do whatever they normally could do face to face. So I know social isolation is really an issue that is extremely difficult to deal with. People are trying to do more phoning and more Zooming, but it's still not the same. No.
Yeah, and I mean, many of these women probably don't have consistent access to computers and internet and that kind of thing. Some of them would, but once again, it would be at public centers, the library or places like that. And just extrapolating from what we've told you, many of them are in poor health. They have chronic conditions. So they are more at risk for COVID and bad outcomes from COVID.
Definitely. And worried about it. I should have said that as well.
Absolutely.
Really worried about being out. And even, the time, I just talked to someone the other day, it's obviously not a participant from this study, but in another context, talking about the sort of struggle between, I really would like to go shopping, like to get my own groceries, because at least I'm going to see someone, like she's on her own. So I'm going to see someone besides myself. At the same time, she has some chronic health conditions, and just worried, especially now that they're talking about the variants of concern, and, just really thinking, boy, I probably shouldn't do that. I should probably just keep, ordering and letting them deliver it to me. So there's definitely some challenging times. And for those women who are working in the community, like these agencies, you'll see the different ways that they are functioning now. They have to. And so a lot of their work is by phone now too. It's not in person, and which is difficult to do the work that way. So those are some thoughts.
Great, thank you. I think everyone else maybe can speak now. If anyone else, I'm happy to open the floor if there are any other questions.
It's Martha here. You may have, I had to step off for a few minutes, and you may have answered it at the time. But did you notice any difference once women reached retirement age and were able to get a pension, whether or not that lessened any anxiety or concerns?
I was thinking about that, so I went back and sort of quickly scanned through some of the interviews just to see. And the one that I found, I don't know, Leila, we talked about this actually, I don't know if you found anything, but the one that I found was really saying that the pension wasn't enough, that they made just too much to get the guaranteed income supplement. They're just out of reach of that. So they had their basic pensions. So for her, she was talking about how that was a challenge.
Yeah.
I don't know if you remember other ones, Leela.
I do remember that one. I think there was someone who was widowed, who was having problems getting her husband's pension. But for the most part, these women were probably not at pensionable age yet. They were between 45 and 65, I think most of them. So
Yeah.
they were just having to work at whatever they could.
Yeah. And if they were of pensionable age, they were still working to supplement.
Yeah.
Mostly, oh, I'm trying to remember. I no, you know what? I'm thinking of another study. I better stop here, Don. I'm thinking of another example, but it was another one we did on women who are living on low income and what they gave up because they were on low income. And I'm thinking about the women who were giving up their pills and cutting them in half and not getting their glasses done properly. Yes, but it's a different study. Sorry. But anyway, you guys can see this had a profound impact on us in terms of just really looking at what's going on around us. And I think it gives an extra drive to really try and engage in ways, whatever ways we can, to try and improve the situation. And some of us, it'll be at the systemic level, and some of us, it'll be at a day-to-day level, one-on-one policy changes, programmatic changes. But there really is a problem here. And yeah, something that we need to try and address in whatever ways we can, wherever we are, I think.
So were all of the participants low income? Because I know you said they were precariously employed, but some people could be precariously employed in higher income type jobs. So
Yeah.
did you have different groups, or were they all just identified?
I suspect those who were seasonal workers had a nice income for part of the year, but it wouldn't have been sustained over the whole time. It would have been episodic. And I did scan through the survey results, and a lot of the annual incomes were 25,000. I don't think I saw anything over 40,000.
No. And just to show the contrast and why we did this follow-up, I've got some of the stats from the first study, and you'll see like the fully 68% of the people that participated in the first study had either complete or incomplete university or a college diploma or certificate. And fully 67% were, well, in retrospect, I think our ranges were too big, but anyway, we had one range from 40 to 79,000, and that was 37. And then 80,000 or above was 30%. So we had 67% of that first study that was making,
and that study had a much broader target population. It wasn't strictly these older women or middle-aged and older.
No, it actually was, Leela. It was 65. It was 45 and older.
Oh, I'm sorry.
Yeah, it was. It was. It was just that we didn't reach those women,
right.
that were at a lower level. Yeah. Yeah. Okay.
So,
Okay, are there any other questions or comments for Leela and Dawn to wrap it up today?
We really appreciate the opportunity to come and do this, and it's been a while coming, but we finally found the time and that worked for.
yeah, and as a nurse, I have to say that a lot of things out of this study raise other questions for research, more specifically around health and healthcare, I think. Anyway, maybe
No,
some
and
students will pick it up.
Yeah, no, and I think it does for all of us, you know, when we think about, and it certainly, as I said before, it really made me think about just a number of things, you know, about how, even though I knew sort of, but about how people were perceiving even those things that one might think are, you know, their services, they should be pretty good, you know, but they're not that good. You hear sort of how people are experiencing them. So for us to hear that, you know, nurse, social worker, important, really important.
Yeah. Okay, well,
Thank you so much. Yeah.
Thank you, Chelsea, for hosting and everyone for coming.
Yeah, thanks very much. Really enjoyed the opportunity to talk about it. And it's got Leela and I going about getting that next project going. We hope we get the SSHRC grant. We'll let you know if we do.
Yeah, it sounds like a great project.
Yeah, lots.
You can come back and share the findings of that one.
Yeah, well, you know what the SSHRC ones are like now, the partnership ones, it's 6 years. So hopefully there'll be something along the way if we get it.
Okay, it sounds great. And well, thanks everyone for attending. Our next talk is on March 18th, just as a reminder, and you can look out for emails from Bree with more details.
Great. Thank you.
Have a good afternoon.
Okay, bye.